Thanks everyone for joining us tonight. I'm really excited because actually I've known Victoria Felix for a very long time, so I'm really excited that she gets to do one of these with us. So just so you know, usually what I do is I'll have the speaker introduce themselves and kind of explain how they got involved in their field of study. So maybe you can start there. And I know you had a couple of comments that you wanted to start with, just
Mhm.
explaining some of what you do. So Dr. Victoria Felix, take it away.
Well, thank you so much, Caitlin, and thank you to the Bobby Jones Foundation for having me as well. Um, so I have a PhD in counseling psychology, and my specialization is in cognitive behavioral therapy. I have specific concentrations in health psychology and women's health. So how I got there, I was always interested in health psychology, and so when I was pursuing my doctorate, I specifically honed in and tailored my training experiences to focus on the impact and the relationship between body and mind. So my research area is in sleep and sleep health, the qualities that impact and the factors that impact sleep health and how that affects your psychological well-being. And then in my training, I focused on health psychology in a variety of settings, but in particular for chronic pain management, I was trained and worked with veterans at the VA across um, across the chronic pain management unit and also in the primary care mental health integration program, which I worked on an interdisciplinary team with physicians, psychiatrists, pain specialists, and supported them in helping in veterans working towards any health related goals. So, for example, diabetes management, so lifestyle changes, um, depression or anxiety that was getting in the way of following through on treatment. And then, with that specialization and with all of that training, I went on to my pre-doctoral internship program where I got the opportunity to specifically apply my health concentration in the primary care clinic for women's health. And so I was able to get into the niche of women's health there, which was a really rewarding experience. And I loved women's health in that niche, in that population. So I stuck with it and decided that for my postdoctoral training, I would get more women's experience, women's health experience specifically. And so I did a 2-year postdoc actually in civilian population in a private practice setting, which is where I am now. So I finished that postdoc and I stayed on with them and I'm now an associate director at that practice. Um, I work with chronic pain and I also work with in that population or in the private practice setting. I've started a program where I'm doing pre-surgery evaluation. So any surgery that you need psychiatric clearance, we do those evaluations, as well as preparing people for surgeries and intervention. So any anxiety going into a procedure or any support with lifestyle changes following that procedure. So I was able to kind of bridge the two in a private practice setting, which has been really rewarding.
That's awesome. Thank you.
Yeah.
So I think I have some questions here. Do you want to explain a little bit about what CBT and ACT are? Because I know those are the
Mhm.
two methodologies that I think would be most
Yes.
beneficial.
Absolutely. So I was going to go a little bit into explaining some of the theories that support how psychology comes into play here. And then I will definitely go into CBT and ACT specifically for chronic pain. And maybe some of those will address some of those questions, but if there are more specifics or follow-ups, we can get into them. So, two main theories that we come to from a psychology perspective around why that's helpful with chronic pain management. The first one is gate control theory, so the pain gate theory. Basically, the idea is that nerves from all over the body run to the spinal cord. And we can think about in the spinal cord, you could just imagine all of these gates, like a series of gates in which messages arrive, and or they arrive to these gates. And so pain messages can arrive at the gate, and then this gate control theory identifies that there are certain factors that keep those gates open and allow more of those pain messages to pass through, and there are other factors that can close them or keep them more narrow so less pain messages can get through. And so that theory, on top of what we call the biopsychosocial theory for pain management, identifies that there are biological, psychological, and social interventions that we can come to in terms of pain management from this multidimensional approach. And so the biological factors are going to be obviously the biological physical pain, whatever physical piece there, that the diagnosis that's creating the pain. And then all of the interventions under that are your medical interventions, your medications, therapies, surgeries, injections, all of those things are under the biological. Psychological is where I come in. I'll talk about CBT and ACT in just a minute. And then the social factors are really looking at your social support, what you have available to you for that, and not only looking at friends and family, but also looking at support systems like this one, organizational involvement. So this is really, really important, and really buffers a lot of the isolation that can happen, specifically around connecting with other people on these kinds of things and these experiences. So those two theories come together in a way that really help us explain why psychology can be helpful and how it can be helpful. I will caveat first, before I get into CBT and ACT, that I really wanted to be clear that you are the expert of your body and your pain experience. So these therapies are here to provide skills that hone that expertise to maximize your quality of life, right? So every time we're talking about any kinds of challenges or exposure therapies around this, I really want to caveat and make sure that it's heard from the beginning that we are first understanding that the pain is there and it's real, and that we're looking to help you figure out within what you know what's workable. So I will caveat that first. And I'll go into cognitive behavioral therapy, which is, again, my specialty, my expertise is in this kind of therapy. This is what I practice very regularly. All of my training is in this one. So what we know about chronic pain and the psychology of it, really one of the major moderators of pain experience from a psychology perspective are your cognitions. What are the pain cognitions that you have that come in and impact the pain intensity, that open those gates? So when we look at those, really we're focusing on what we call cognitive distortions. Whenever you're experiencing pain, your brain is wired in a way that's going to develop more cognitions that are more rigid and more very like hyper focused on the pain experience, which does have a tendency to open up those gates a bit more and have the intensity be even higher than it already is that you're physically feeling. And so some examples of these cognitive distortions, all or nothing thinking is a big one. So it's either going to get better or it won't. I'm going to go to this event or I'm not. There's not really a lot of room for the gray in that. Magnification is another one. So taking a magnifying glass and putting it right up to the pain experience. Usually magnification, one that I hear a lot, is the what ifs. What if my pain gets worse? What if what if nothing helps, right? Those are big magnification thoughts. Overgeneralizing is another one. So like, because this intervention didn't work, nothing will. That's just an example, right? But this idea that we're taking one thing and then we're generalizing conclusions and then predicting the future, right, based on what happened in the now. And I just also want to say that these are things that our brain does to us even outside of a pain experience, right? So these things might, and some of these examples might come up even just about other things, but specifically around pain, the interventions are going to be looking at which ones are yours, which ones are your go-tos, which ones do you get stuck in the most, what do you hear your brain saying, and we're going to teach you the skills in cognitive behavioral therapy to identify, evaluate, and challenge those so that they're really in line with what we know is the whole picture of what's true about the pain experience and your self-efficacy in managing it, so that you can go out and modify with modifications, do things that are not so tied to what the thinking is saying, right? Because when the thinking wins, our experience can be narrowed, and that's what we're looking out for. So I think a quick example that I can go into on this is, for a thought could be, I can't go to this party because it's going to cause a pain flare up, right? And that's an all or nothing thought. That's a bit of predicting the future as well. So we would ask, what is true? What is true about that? Let's start with what you know is true about what causes your pain flare-ups and figure all of that out, write all of that down. Do we have any evidence to support that specific thought, I can't go because it will cause a flare-up, is not true? And that's where we really have to, that's really where the restructuring skill comes in. And sometimes we don't know, sometimes we have to try. Sometimes we have to try things and see, well, what am I willing to try to get some evidence here? But if you know, for example, that standing for a long period of time is going to cause that pain flare up, then we work together and say, okay, well, what kind of plan do we have to come in with so that you're able to go to the party, right? So we can maybe go through some of that, and then with the evidence, restructure the thought to say, if I pay attention to not overexerting myself and follow the plan to make sure that I'm following my pain management plan, I can go to the party without activating a flare-up. So that would be a really good example of how we would engage in just one of the skill sets in CBT, which is the cognitive restructuring. Another big part of CBT is the behavioral aspect. So we're looking at active coping, pacing. So there's a lot of skill sets around how do you pace yourself to find where the pain flare up could, like where is that inflection point for pain flare-ups to happen, and how do you pace yourself so you don't get stuck in an all or nothing approach. Mindfulness and relaxation, which we'll talk about. Symptom tracking to understand more about things we might not look for, that kind of data. And then things like communication skills and boundary setting with other people around advocating for yourself, and especially like in the healthcare system, advocating for yourself and what you need. So overall, CBT is looking at increasing your sense of self-efficacy with pain management. That was that in a nutshell, and we can go into more questions about it if that makes sense.
Yeah.
And then I have some information about ACT that I can give, so acceptance and commitment therapy.
Do you want to go over that first, and then we'll go through some of the questions?
Sure. Okay, so ACT is looking at the basic tenets of ACT in chronic pain specifically. We're looking at what is the relationship with your experience of your pain, right? So with the relationship with the experience of it, and also values guided living. So those are like the two basic things that I'll touch on. So ACT talks a lot about getting stuck in the struggle with our experiences. So for in chronic pain, right? How are you stuck in the struggle with your pain? And how would you define what that struggle is? What does your mind do with it? And how does it take you away from what matters to you in your life? I think that's a big pillar point in ACT is the acceptance and committed action piece. So the acceptance part, which I want to make sure is clear what acceptance is not. Acceptance is not saying throw my hands up in the air, I accept that this, like I surrender to this, right? This is what it is, right? That's actually a very passive relationship with acceptance. What we're looking for here is this choice to be open and willing to whatever the present moment brings. Whatever your experience is in the present moment, you're open in that you're experiencing it in a non-judgmental manner. The crux of this is saying what we're trying to separate is the present moment experience and the negative associations that come with it. So ACT really is looking at how are you in the present moment, whatever's going on for you, not you're just experiencing it as is and moving in service of what matters to you in your life. And so that I'll go into it a little bit more maybe when I describe the differences, but we're really looking at a series of processes and skill sets to separate the content of your thoughts and focus on the anchoring in just this is the present moment experience and the process of moving in the service of what matters to me. So not really getting so stuck in the struggle really is kind of a summary of that. Yeah.
Okay. I guess before we move on, then, can you just talk about what the differences might be and between, and there's actually a couple of really good questions that came in the chat too that I'll ask, but what's
Yeah.
the difference between CBT and ACT for chronic pain specifically?
Yeah. So I would say
Recorded.
one of the biggest, oh, sorry.
No, you're fine.
Okay. One of the biggest differences between them and how I would conceptualize them is the CBT is really getting into the content of your thinking and saying, let's dive into this content and let's evaluate it and let's learn how your brain is chunking information and get really curious about if it's meeting the facts. Whereas ACT doesn't really get into the weeds on the content of the thinking. ACT is really more about process. So ACT is looking at if that the thought that comes in, we could challenge it, but why? Maybe that's just the struggle. The thought that comes in is what's the struggle that you're experiencing with the pain. That's one way that you have that struggle, and really focuses on if you give into that thinking, are you moving in service of a value for you, or are you moving away from what's important and you're colluding with the struggle? Right? So I would say CBT is more content and ACT is more process in theories, while there are a lot of overlap though in them in terms of behavioral approaches and also just like moving towards goals that are important to you.
Yeah. Okay. I'm going to ask this question because it's specific to CBT, and I think we're going to talk about. I don't know if we have one already about this, but so the way it was worded, anatomical abnormality causes chronic pain. We know that chronic pain causes damage, and that can cause cognitive dysfunctions that you were talking about, and that can then cause more anxiety. So really, the question kind of gets down to how does CBT specifically recognize and approach all the difficult emotions that kind of come up in those gated pain experiences? Like, how does CBT address the emotions that are caused by this cascade?
That's a really great question. So CBT is really looking at what is the relationship between your emotions, thoughts, and behaviors, and really that they're like the question names is that there is a cycle there, right? So if there's an intensity in your emotion, then your thoughts are more likely to be rigid and get stuck because the intensity drives the rigidity of the thinking. And then that branches off into whether you engage in behavior that is like in line with the thinking, and if you usually it is, right? Like all three usually work together as a team. So in CBT specifically, we are looking at navigating what is your thought process, and if we can challenge the thought and get it out of a trap, that reduces the emotional intensity, right? So we were looking for what thought process that is coming from the anxiety, right? So anxiety is pushing through like all or nothing thinking or fear-based thoughts. And we come in at the thinking and say, okay, if we can balance this a little bit more, that's in line with your self-efficacy, you feel more in control, that anxiety comes down. I will also say, we're looking to with emotions that they're messengers, right? So emotions are messengers. The thing is, the message can sometimes get lost in how intense they come through. Like if they come through super intensely, we can get lost in kind of like the the experience of that, right? So another skill set that we look at is, what is the kernel of truth about the message, right? And in terms of just navigating coping skills for that emotional intensity, we've got to work on some of that breathing, some of that mindfulness, or whatever emotion. Like opposite action is another good example of like, in this moment my anxiety wants me to do, blow everything up, and I'm going to do the opposite for 5 minutes, right? So we kind of look at regulating those skill sets so we can hear the message. That's the kernel of truth in what the intensity, they're saying it very loudly, but there's a kernel of truth in there that we have to make sure to address cognitively.
Yeah, and that kind of dovetails really well into, there's a question that came up about emotions being physiological, which you kind of alluded to just there. But so I guess to follow up, what are the ways that you can manage emotions and stuff like that? I know you talked about mindfulness and relaxation.
Mhm.
And I have a follow up to that that I think we've talked about before. But I guess what are those things? How do they work in the brain, and can that help?
Yeah, yeah. So the intense emotions are actually some of those um those things that are going to open up those pain gates, right? And so looking at some skill sets, and some of this is actually also really helpful just outside of pain management, but also just in general in terms of like any other, just largely dealing with other people or dealing with like stressful situations. I'm I'm going with anxiety here as maybe an organizing emotion as an example, but the fight or flight response is very much attached to um, the chronic pain experience. And so we're looking at is your body is probably, because of the physical pain, there is a chronic tension, right? The body is under this chronic tense, and the way that your nervous system reads that is through fight or flight. It's through fear, through anxiety. And so what we can look at are skill sets like mindfulness, skill sets like relaxation, but also like I was saying before, the way that fear makes your thought process go into, I can't handle this, this is never going to get better. We really want to get to what are those, like where are you going with the thinking? How does the emotion drive the thinking? And we in CBT intervene from that point. I will say that DBT, dialectical behavior therapy, is another really great therapy, another spin-off from CBT like ACT is. DBT does focus a lot more on the emotions though. So if you're saying, if you're someone who's like, I don't even know if I get to the thoughts because the emotions are just so loud, I would say looking into distress tolerance skills. So I'll give you a couple of examples. Distress tolerance skills are looking at how in the moment, the intensity of the emotion um, makes it really hard to even get to the cognitions or rational thinking. And you can experience that a lot in your body, like the question had mentioned, right? And so I would say with distress tolerance, and we'd have to modify with pain, right? Modify these interventions with pain, but we're looking for how can you physiologically bring down that intensity. So what do you do when you get really anxious? behaviorally? Like, where does that intensity bring you? Is it like complete withdrawal? Is it like complete shutdown? Then we have to say this skill set that we call opposite action, which is let's do the opposite of what the emotion is pulling for you to do in this moment. And in DBT therapy, they can I think in any of the therapies, right, they can really help you make a specific plan to the way you specifically experience it. But opposite action, I think, is one of the ones you'd want to watch out, or ask about or watch out for, or read more about, in terms of, for example, my anger is making me want to like punch someone in the face right now. Let's actually just sit on our hands,
Yeah.
right? Things like that, like little examples like that. But letting the emotion peak and then fall is really important, especially under a body system that is constantly put in a position of chronic stress. Usually what we do where we get it wrong is we don't allow emotions to peak because we're too scared of the feeling to get it to peak,
Yeah.
to let it fall. So we develop skills to tolerate, okay, it's peaking, I can feel it, but I'm not so scared of it, because you work with your therapist and learn what that is for you specifically, and then
Yeah.
it falls, and then you didn't add to it with all of the ways that the emotion tried to pull you in. Does that help to address that?
It does. But I also just, can you explain mindfulness and relaxation specifically? Because I that was great DBT. But
Okay.
I guess what are those things? And I will have a follow-up after this.
Sure. So I think it's important to distinguish those. They're different and they do different things, but sometimes they can be lumped together. So mindfulness is actually looking at this like intentional way of being in the present moment. So teaching you a skill set, and this comes into the acceptance part of ACT that I was talking about before, which is what is occurring in the present moment without attaching it to negative associations. So mindfulness practices train your brain to allow, your brain is going to want to wander, right? Our brains purposely do that. We are in the future, we're thinking about what we're doing after this, we're thinking about that thing that happened 20 minutes ago that we're still noodling on, and here we are doing this in the present moment, right? These activities and these exercises help you focus on, it's okay that your mind wanders. How can you bring it back to focus? How can you kind of bring it back to, this is what it is in this moment. This is where I am, present moment. This is what I can see, smell, taste, touch, right? That could be a mindfulness anchoring example. And what we're really trying to do with chronic pain is separate pain sensation from unhelpful thinking. So I'm experiencing the pain in this moment, I'm sitting in it, and the thoughts are coming, and I'm having the thought that this will never get better. I'm having the thought that, versus this is the thing I'm thinking is true and I'm going to camp out there. This thought is going to park in my brain and then it's going to create traffic because all these other cars are going to come in, right? That would be what mindfulness helps you do. And then relaxation is really addressing that pain stress cycle that I was just mentioning, about how your body is under constant stress. So there's chronic pain and there's chronic stress, and an accumulation of this consistent practice in relaxation. So things that help you to move the tension through your body, through usually the breath, is a really common, through relaxation exercise. So like diaphragm breathing, right? And I'll also caveat, I know that there's a lot of different modifications that can be made to these because everyone's coming in with very specific needs for their their pain in their body. So with relaxation exercises, trying not to get discouraged if one of them is not going to help. The purpose is to help you relax. So if it's not helping you, find another one. There are lots of them out there. But that would be the difference between the two.
Yeah. That's like a perfect setup for the question I was, and I know we've talked about this before. Um, as far as mindfulness is concerned, I remember we had a long time ago, there was like someone did a mindfulness body scan like session, and I
Mhm.
remember a patient had told me that they hated those because all it did for them was kind of like point out all of the parts of their body that hurt, and
Mhm.
they felt worse afterwards. So I guess, like, are there specific um mindfulness exercises or relaxation exercises that like don't work, and do you work with your therapist to kind of figure out what those things are? What do you do?
Yeah, that's a great question. I think that it's really an individualized plan. Absolutely. I mean, any time we're working with chronic pain and just in general, there are I kind of want you to think about these skill sets as we are throwing darts and seeing what sticks, right? So and that's also where that self-efficacy comes in. I want someone to come in and say, I didn't like that so much, right? Because that's your voice. That's you taking ownership of yourself, your pain management plan, right? And so we can get curious about what about it didn't work so that we know to make sure to plan around that and see if there's anything that we can modify. But just as long as we find something that works, right, that is around bringing down that tension in the body and building a consistent practice. I think something else too, I'm glad that you brought that up, Caitlin, because I think a myth that comes up with relaxation exercises is that we're supposed to feel better right after we do them.
Yeah.
And how annoying is it when we don't, right? Like,
Yeah.
why did I just do that? I thought it was going to make me feel better. Like I said before, it's really an accumulation of consistent practice that the way you feel after is the way you feel after, and you're sending signals to your nervous system that it doesn't have to be in fight or flight quite so much, right? So especially when the tension's really high, we're not necessarily like the baseline tension, if it's at like an 8, we're not going to feel relaxation at a 0 after a breathing exercise. We can't expect that, right? But we continue to practice that every night as part of a nightly routine. Then we are bringing down that overall fight or flight stress at an 8. Could we bring it down to a 6? We'll take
Great.
that, right? That's a big difference. And so setting some expectations around those exercises can also help because people can get pretty frustrated in them, like mindfulness exercises. They can be frustrating. Yeah, our brains are they want to do what they want to do, and we have to come in and train them. That
Mhm.
takes time and practice.
Yeah. And understandably, it's really hard to do if you're also hurting. So like I completely understand that that's really frustrating. A question came in. This is interesting. What would you say about the balance between coping with pain and the recognition that pain is like in and of itself, it's becoming this pathological anxiety process? So they mentioned this particularly in that the medical concerns of women are often dismissed as, just all in their head and stuff like that. So I mean, especially in your area, can you speak to that a little bit? I don't know.
Yeah, so are you, I just want to make sure that I'm getting it right, that we're differentiating between like the kernels of truth between the like there's pathologizing that can happen here. Is that
So,
like speaking
well,
to the pathologizing that can
it's
happen?
almost like trying to determine what's physiological versus psychological, I
Got it.
guess.
Yes. Yes, yes, yes. That's a big part of the work in CBT because I think it is very, very important and very empowering, especially in my work with women from a feminist perspective, is to say you are the expert about what's true and you're going to be put in situations where you have to advocate for yourself and to know what you're advocating for and why. And we can get confused within ourselves because especially women are going to maybe internalize, justify, minimize a bit more. So I'd say looking at what's the difference. one of the key skills that CBT can help with is discerning, where is my thinking stuck in a trap? What are those traps? And knowing, okay, there is a kernel of truth in every trap. We've got to find what that kernel of truth is. So, sure, like the experience of pain, there could be like, and this is again a sloppy example, it's a very extreme example, right? But that like nothing is ever going to change. I'm never going to feel better, right? Sure, that one is a really obvious one where we can say that's getting stuck in a trap. So why don't we, where's the kernel of truth? And what's true about what is true about how you feel there too, right? What there's a sense of wanting to get some mastery, but also navigating how hard it is to feel mastery over something when you've got to come at it from all of these angles and can get stuck in the desperation of it too, right? So I'd say one of the biggest differences in figuring that out is, what are the cognitive distortions that come up? And again, like CBT is really helpful with naming what those are specifically for you, and then looking at, okay, what am I willing to go out and find or learn if I can't find any evidence to challenge that thought, right? Like, and usually I also say this a lot in my work, the data is very organizing. So when we look for data and you're trained to look for that data and to see it, it's very organizing. Then we're not sitting and wondering, is this true? Is it not true? I'm not sure, because you are an expert in your experience. And so the distortion just gets in the way of you seeing that. So if we clear that up a little bit, you're going to be able to discern more, what's my anxiety and what's the pain.
Yeah. Um, there are a lot of good questions that are coming through, but I'm gonna try to ask some of the questions that came in earlier.
Okay, sorry. I'll try to make them
No,
shorter.
no, no, it's not you. It's
Get
not you.
to
A lot of really good questions they're not easy to answer succinctly. So, but this is kind of one that came in as well as one that was earlier. So, can CBT help with quote unquote brain fog? So I'm sure you know a little bit about that. A lot of chronic pain patients, they say that they find it hard to focus, word finding is difficult. Um,
Yep. Yep.
that's in and of itself a symptom of Chiari and different disorders as well. So does CBT, can that help with that? Is there something else that can help with that, psychologically speaking?
Yeah, yeah. So I think that looking at brain performance and those cognitive symptoms, I think that we would usually start on the behavioral interventions. So we're starting with, what do you know about what activates, what makes it worse? What are you already doing that helps, right? So I'm first looking into, what are your activators, what are your exacerbators, and getting really curious about those. What have you done? What have you tried? What are you willing to try? One of the biggest things with the cognitive interventions around these symptoms are the impact of the experience on your self-concept. I think something that we really do know about the pain gate with any kind of cognitive symptom is that there's a level of stress, frustration, and even sometimes depression symptoms that can come in navigating those. And those all together come in and exacerbate the pain gate, right? Those send more messages. And so, yes, while CBT has these specific skill sets for what is your coping plan and behaviorally, what can we try? And also, like, how can we make sure that you are managing the nervous system, because the nervous system plays a really big role in cognitive performance and brain fog. So we do a lot of nervous system training, right? Mindfulness and some simple distraction techniques, and just different stimuli coming in from different stimuli. Those are all some of the coping strategies that we could come in with that you've already tried too. We can just kind of give the frame around that's the self-efficacy. The other piece of it, like I'm saying, is the stress and the self-concept piece is also very important, because the way that you're thinking about having that experience and how that sticks for people can make them feel less have less self-efficacy, when actually it's like, no, wait, what are all of the things you're doing to manage a really difficult cognitive experience? So I think it's definitely, yeah, definitely workable in the CBT model for sure.
So there are a couple of questions about like the pharmaceutical stuff. So I'm going to ask this one first because this is about using them. So are psychological medications the best route? If so, those messages are firing and they're not supposed to be, or they're not firing, or is it just coping techniques? Where do pharmaceuticals kind of come in to help with this?
Yeah. So this is something that I say pretty generally, and obviously don't prescribe medication, so I don't want to speak too out of turn on this, but this is how I work with this kind of decision. First of all, I think that there's a level of preference. So some people just prefer to go the SSRI route, right? And say that that's something that I'm really comfortable with and will help balance serotonin, and I'm here for it, right? Other people are, I'm taking enough medication, I don't want another medication, and they go the therapy route. I I kind of sit in this place of, first, know your preference, and then second, CBT can be just as effective as medication if the skill sets are following through. The two of them, CBT and medication together, are even better, right? So I usually stick with, if someone's coming in to see me for CBT and I'm noticing that they're working harder than they need to at the skill set, then that's when I say, okay, let's maybe see if we can get a psychiatric consult, because there are there are aspects of this that we can come in and target and change and follow through on. It's CBT is a very active therapy, so we have a lot of homework, a lot of, it's work, and I don't mean that in a negative way. It's just that it can feel really hard to do, and if it's too hard, right? It should feel hard to some degree because we're changing the way we're thinking, but it should also feel rewarding. If we're
Right.
not, if we're like just like in the mud on it, um, I usually recommend medication,
Okay.
consults at least. So that's usually where I stand on that, and say, go with your preference, but if you want to do an experiment where you try CBT first, and I usually say about 4 to 6 sessions is when we first start feeling. Give CBT at least 4 to 6 sessions before you start feeling, but that's as early as you'll start feeling a difference. So if you're not feeling a difference around then and you're like, I'm doing all the skills and I just can't quite grasp it, that's maybe a good time to maybe ask your therapist about it, talk about it more.
Yeah. Yeah. Um, and to that, the opposite point of that, there are a lot of questions. So a lot of these patients are already on a lot of medications, like you were kind of saying. So non-pharmaceutically, what are the different things that these people can do, like day to day, that will help them reach those goals that they're setting, maybe in therapy? Is what is it that they should be focusing on to avoid another pill?
Yeah, I mean, I think again, it's going to be very individualized to your therapy experience, but following through on the willingness and the homework assignment. So again, CBT for chronic pain is really going to be focusing on, every week you're going to have another exercise to try. And when I say exercise, I mean like another skill set, another tool to try, right? And if it's if the tools, are sticking, then they breed more tools. But if they're not sticking, you're spinning your wheels. So I would say if you're motivated and in it, um, following through on those homework assignments and trusting the process can then along the way help you feel really, at the end of the day, we want you to feel more self-efficacy. And if that's what's coming up as you're doing this stuff, then you're on the right track.
Yeah. I want to ask this question, but I also want to leave it for later, so I'm going to skip this one for now. I thought of a question that I wanted to ask. But I guess I'm going to go into this one first then. So a question came in about nutrition, food, eating, stuff like that. It's
Yeah.
obviously important for pain management, even just surviving. So this person had written in saying they're having a really, really hard time not eating foods that they know it's bad for them.
Yeah.
And feel like their therapist isn't really helping. So how do people really focus on proper eating and nutrition, especially if you are in pain? I mean, it can be a lot to focus on.
Yeah, absolutely. That's a great question. I think, I can answer it from not only a food perspective, but also just any kind of lifestyle change perspective, that really we're looking at what is the mindset around the approach, right? So I think when we get into lifestyle changes, we can get really stuck in all or nothing. And we're either like, I shouldn't have this at all, or you know what? I'm tired, I'm exhausted, I'm in pain, I'm having this, right? And you can vacillate between the two. And then there's this like guilt cycle that comes after, and this like the shoulds, I should have done this or I shouldn't have done this. And it really leads to this kind of like cycle that reinforces it more, right? And then I feel guilty, and then I and feeling more depressed, and then I make other choices that are in line with that depressed feeling, whatever it is, right? So we can get stuck in a cycle. And I think anytime we're looking at lifestyle changes, we really want to make sure that we're not getting stuck in a deprivation mindset. The balancing of that, right? I want to get really curious about if that deprivation mindset is, I'm being deprived. If there's a deprivation in other areas, there's a deprivation and I shouldn't have these things, and then it vacillates to whatever, like, have more of the food, or I'm going to do less of the exercise, whatever it is, right? And so what we're really looking at there is, I think, two things. One, balanced mindset. So how can we make a plan where there's room for indulgence? And then there's also different coping in those urges. I think another thing we just have to name here is that, especially food and foods that are like fun, have a chemical component, right? There's a chemical and a dopamine response that's going on there as well. So the urges are hard, they're hard to manage. And so we practice skill sets of like, what do I do while that urge is there, and let it rise and then it falls. Same thing with emotion, right? We let it rise and then we let it fall, but we come in too early when it's peaking and give in. So skill sets around managing that, I usually get really curious about the environment. So setting yourself up for success in terms of your access, in terms of what's easy to do, and having some distractors, right, during that urge, so that you can build up a sense of, okay, wow, I had that urge and I didn't give into it, and that felt good. Is really, that becomes reinforcing over time as well.
Yeah. Thank you. So this is a really good question. I don't know if you can speak to it, but I'm going to ask you about it. What are your thoughts on combining things like vagus nerve stimulation in conjunction with mindfulness and CBT? Is there any validity to stuff like that? I don't even know if you've seen that used in conjunction with CBT and different things, but different stimulators, or even, I guess I would even go through an injection, stuff like that. Do you notice that that's more efficacious or less?
I mean, I want to answer generally,
Yeah.
And I would kind of go with, right, that this from the biopsychosocial approach and the multidimensional approach, that we're coming at this from a variety of interventions. And so finding the ones that work and a combination of the ones that work are going to be better than any standalone. Um, I don't think there's not a wrong way to combine the CBT in with injections or other kinds of interventions, just as long as the mindset is all of these things are coming together in a way that I know manages my pain effectively for me.
Hmm. Um, thank you. So I don't know, you kind of addressed that one, so I'm going to skip it. I'm going to ask this one because it's kind of like the elephant in the room a little bit, and I know we talked about this before. As far as the opioid crisis is concerned, I know a lot of patients, and you have some experience with this.
Yeah.
Um, they they need psychiatric even clearance to get those medications, stuff like that. But even being unable to get those meds and to manage their pain effectively from the biological standpoint, that can really mess up the social and the psychological stuff that you're talking about. So, what's your experience with that? Do you have any thoughts how you manage that kind of stuff?
Yeah, absolutely. Yeah, it is the elephant in the room, right? I mean, anything around kind of the opioid crisis and conflict there, right? That there's a lot of historical and political context that we just don't have the time in 6 minutes to get to. But what I will say is a lot of experience with this, especially at the VA. I was running a chronic pain management group where majority of the vets that came in, their opioid prescriptions were either discontinued or decreased pretty significantly. And it is a very frustrating and despair causing experience. I will say just kind of globally that what we know about in the chronic pain population is that there is a risk with the opioid crisis to be undertreated with opioids, and that creates more despair, some more hopelessness, frustration, and it's really hard. And yeah, people come in to me like pissed about it, which I'm like, yeah, I hear you. Yeah, absolutely. And I think that where I can come in terms of navigating this, right? Because there's there's a minimization that can happen in the healthcare system. There's a stigma that happens with navigating these prescriptions. That affects your mood and it affects your motivation to feel self-efficacious. So that's where I'm coming in to say, okay, um, how is this experience kind of impacting and that angle impacting your psychology, the psychological angle? How is that bringing in depression, more anxiety, and really supporting and helping with that to build up where do you have control? Because again, I can't even prescribe the stuff. So, we kind of sit in what we have control over, and to say, um, yeah, well, can we make any traction on what we can control in here from the psychological standpoint, even in responding to the stress of that situation? Because that's also now adding more suffering to the story. That's where I come in, but I also understand that it impact people's motivation and feelings of engagement. And we sit with that in the room a bit while also saying the psychological components is what we can control in here, so that's what we're going to do. Let's build some of that from that agency perspective. Yeah.
This is a question that we get a lot. How does someone navigate the situation where maybe they have family that or friends, bosses, coworkers that are a little bit more dismissive of their illness or pain. They don't really understand what patients are going through. So how does how can you really work through that? I guess in therapy or even just on your own. Like, what should patients do in that situation?
Yeah, it's really hard. It's really tough, and it again adds suffering to an already really difficult experience. And so I would go with kind of two takeaways on this. One, boundary setting. Stick to your boundaries and advocate for yourself without you don't have to justify, right? I think that that's a pull that can happen. Oh, you're not going to do this thing. Oh, like just come on, right? That there's a pull there. Um, and kind of sitting in what and really entitling yourself to knowing what you know and setting those boundaries within your pain management plan. The second would be expectation setting. And what I mean by that is what do you know about the person that you're interfacing with? And what should you expect from that person realistically? Because we don't want to be disappointed every single time. If we've been disappointed once and twice and three times, then I know it kind of sounds a little grim, but we expect, okay, they're not going to get it. Let's just put that on the table rather than the struggle with
Hmm.
maybe this is the time they will.
Yeah.
And then to say, how do you still navigate, and this is where ACT comes in really nicely, is like, how do you still navigate the relationship in a way that's moving toward what's important to you? Is this relationship important to you?
Mhm.
And how can you engage in that relationship in a way that is kind of separate from the expectations around them understanding your experience? Since it can be hard to kind of set that aside, but that's an agentic choice that we'll make then to say, this person's still important to me. I'm not going to go for them for these things. Or if they make these comments, I'm not going to personalize them.
Hmm.
So really building up the not personalizing piece is really helpful, I think.
Yeah. Yeah. A question came in just to jump back to the the neurotransmitter kind of
Yeah.
end of it. So is a neurologist someone that would help with that, or is that something that you can work through in psychotherapy that can almost not treat, but rewire those those gates even? Is
Yeah.
that something that can be done strictly through therapy, or do you have to see a neurologist? Is there some other kind of specialist that you would recommend to kind of interface with that?
Yeah, I would sit with, I guess it kind of depends on what the symptoms specifically that we're talking about are, but that because we're looking at this through the biopsychosocial model, there will be things that the psychology does play a role with and a weight with that can help with um, the pain messages not going through as much, right? But the caveat being, if you've gone through that and you've graduated from CBT and it's not a standalone, right? So like obviously you're doing a bunch of other things in managing your pain, but that if you go through a course of CBT and there are still aspects of your pain that are not really being addressed, you'll probably learn that in the course of your CBT work and then can go to the appropriate specialist from there is what I would say. But again, with the biopsychosocial model, you could start anywhere.
Yeah.
And I would say in your pain management plan, making sure that you have professionals from that tie in from each one. I mean, obviously the social piece is separate, but from psychology and from the biology can help you then discern what's missing.
Hmm. Hmm. So this is the question that I came up with, and sorry for making it up on the spot. I don't mean to put
Love it.
you on the
Go
spot,
for
but
it.
I think this is important actually. Is there any way to know if you're not ready for therapy? So like when a patient comes into you, like what are like kind of the prerequisites that you're hoping that they've either already worked on or that they're ready to do? I
Mhm.
guess like they need to know when they can interface with the social psycho part of the biopsychosocial model?
Yeah, I love that question. Really willingness to participate. That's all we need. We need willingness to participate. So um, I would say if you're considering it and on the fence, not sure, but want to give it a try, that if you find someone that you feel comfortable enough with, that you can build a rapport with, that you trust a bit, the fit is very important. Willingness to give it a go is really the only thing that I'm looking for with people coming in. They don't have to have any other kind of experience in pain management at all. They just have to be willing to give
Yeah.
things a try.
Okay.
Yeah.
And then sort of as a follow-up, just because I know this is true for a lot of people outside of pain, even just in therapy, how does someone know if maybe the fit isn't good? How do
Mm,
they know if their therapist maybe isn't adjusting what they need to, or if, I guess, how do they figure that out?
yeah. I think it's a feeling. Um, well, a combination of things, right? So sure, there's fit for like competence, right? So if like you just don't feel like this person gets the specialization that you need, then keep it moving. And obviously, like if you're coming in for a specific skill set and you feel like you don't understand how the things you're doing for homework are part of that skill set, or that you're not getting any homework to do, then you're like, what am I doing? Those could also be indicators. But I think if you're leaving sessions feeling like your therapist doesn't fully get it, or isn't kind of, it's hard for you to like feel like we're on the same page, then yeah, that can disrupt the relationship. And I think people sometimes either stay too long or in that or don't really know how to handle it, because it can be awkward. But I would say the first step could be to give some of that feedback to the therapist and say, this is what I'm noticing, this is how I'm feeling, and see if any adjustments come. If not, and then you don't have to give the feedback, you could also just see you later. But if you're interested enough in staying with that person, you could give them the feedback and give that a try. But it's totally fine there. It's a whole market out there, and you'll find someone else. Usually I say, when you're looking for therapists, usually they offer like 15-minute free phone consultations. Set up phone consultations with a few of them, maybe two or three, and then go with one that you kind of connected with the most, and then take it from there. But trust yourself and how you feel. It should feel like there should feel like a flow in the relationship. If it's not there, it's not the best fit.
Yeah, thank you. So I have two more questions. If there's any last questions, please put them in the chat now. But this one's important, and you kind of like started to talk about it at the beginning of, excuse me, the session. You said that you kind of see people before they go through a surgery. So this question is really specific. It says, what do you recommend for helping with those strong feelings that people have when they're making a decision about undergoing brain surgery specifically? I mean, it's a really invasive and stressful thing. So
Mhm.
what do you recommend for those people, and how do they interface with you as a therapist specifically?
Yeah, I would want to get really curious about what like obviously the specific surgery, what you know about the all of the facts that you've considered to make the decision to do the surgery, and all of the collateral information that you have, your trust of your surgeon, your fit with your medical team, and what are some of the fears that are coming in, and how are we holding those in a way that again are in line with the facts, but are also saying, I am aware of that the risks of this don't outweigh the potential gains for me, right? And so sitting in and really tolerating that it's not gonna, like, that there might be just um those like little wedges of doubt that you hold on to, right? But we get into what's productive and what's unproductive, especially once you've made the decision,
Mhm.
right? And really anchoring in how does your brain try to like go into all of these loops and what ifs that actually increase your stress after you've made a decision for all of the reasons that you've identified. And usually we'll also collaborate with your medical team there to also help to navigate, for example, what are all of the facts that are available so that I can also help to discern where is anxiety coming in and putting that cloak over the data
Yeah.
and dispel some of that if there's any of that to do. If not, then a big piece of it is not getting into the negotiating after the decision has been made and sitting in the feelings of that and doing a lot of emotion regulation training to get you prepared for that surgery.
Yeah. And then what about after surgery? So, at least in Chiari patients specifically, like sometimes symptoms take a long time to go away. Sometimes they never go away. I guess like as far as that's concerned, um, is that CBT? Is that something else specific that people have to work through to kind of be okay with that situation?
Yeah, yeah. I mean, I think from a CBT approach, what we want to do is kind of sit in what are the facts here and how are we going to use what's actually true to make a modified quality of life plan for you so that there are going to be points with navigating the story around it, the story around what it means about you that these things are still here, what it means about your life if these things don't go away, right? And how does that impact the way that you're viewing your self-efficacy through that. So we don't change the facts, right? We can't do that, but we do say is what's the frame that we put on them that's an adaptive and functional frame with what we know is true.
Yeah. Okay. And then just to round everything out, um, how can someone find a CBT or an ACT therapist or even a DBT, dialectical behavioral therapy? How can someone find someone like that, and how do
Yeah.
they?
So a couple of resources. So one really common one is Psychology Today. Most therapists have a profile up on there, and you can search by like ACT or CBT or DBT. Another great resource is the Association for Behavioral and Cognitive Therapies. That website has a directory, and you can filter for a CBT therapist, an ACT therapist, or DBT therapist. There's a bunch. Like there's a marriage therapist, ABA therapy, there's a million. So you could specifically search for those, and they have a database of certified therapists, certified trained therapists in behavioral and cognitive therapies all over the world.
Yeah.
So either
And
one of those.
so just on those resources, I know it's very specific to where you live. Is that information available there too, like where those psychologists practice and stuff like that?
Mhm.
Yeah,
Yep,
yeah.
yep, absolutely.
Okay, good. So if there's no other questions, I want to thank you, Dr. Felix, for coming on tonight. It was really great. This was
Good.
awesome. And you're actually going to be at the DC
Mhm.
United at the Hill too, which is going to be awesome. So I'm really excited about
Yeah,
that.
looking forward to it. Yep,
Awesome. All right. Well, thanks everyone for joining us, and thanks, Dr. Felix, for being with us tonight.
you got it. Thanks, everyone.
Bye.